Hi there, welcome to a pharmacy revision series by CBH Education. Today we're going to be talking about phenytoin. Now, in this presentation, we're going to talk about the categories of anti-epileptic drugs. We're going to talk about phenytoin and mechanism of action, the monitoring, the side effects, the MHRA warnings, an example of a calculation question and pre-registration question. Okay, so you've got your different categories of epileptic medication. So to set the scene, phenytoin is in category 1, carbamazepine is in category 1, phenobarbital and primidone. When a patient is started on this for epilepsy, it's really important that they are on the manufacturer's brand or a specific product. This is obviously initiated by a specialist and carried on in primary care. Some of the issues you get is patients being started on carbamazepine, for example. You haven't got a dose, you haven't got a formulation, and you haven't got a brand. Community pharmacy is essential that if you've got an epileptic patient taking those 4 medications, they are on a brand. Category 2 is discussion with the specialist or the clinician about maintaining on a specific manufacturing product, which you don't need to do because it's based on clinical judgment. Category 3, you don't have to worry. Where some of the other things link in is with phenobarbital, for example, you've got the controlled drug regulations. Phenobarbital is a CD3. It can be given as an emergency supply for the treatment of epilepsy for that purpose. And you've got to know, obviously, the duration. You've got to know the requirements around recording emergency supplies, which we will cover on in a later presentation in our revision series around the legal aspects of prescribing as well and giving out drugs to patients as well. Now, what's really important about the whole category 1, category 2, category 3 is that knowing about carbamazepine, phenobarbital, phenytoin and primidone, this is going to get presented in an OSCE situation to you or on your pre-registration exam as well, and making sure that you understand this is absolutely vital. So phenytoin blocks the sodium channels and stops the firing of action potentials. Phenytoin has a lot of side effects to it, so some of the key things is looking for blood and skin disorders. Drug interactions is an enzyme inducer, so there's a great deal of interactions. Again, we'll be covering more on enzyme inducers and inhibitors in a later presentation. The key monitoring is the plasma phenytoin concentration. When somebody's newly initiated on phenytoin, it's about recording that plasma concentration, making sure they're within range. Obviously, if they're out of range and they're above the range, you've got an increased risk of toxicity there as well. Now, obviously, doses can be adjusted. And one of the things here is also about LFTs as well, making sure that those are monitored as well. Revision to help you support you with your exams. So obviously you need to know about the plasma phenytoin concentration, which is 10 to 20 milligram per litre or 40 to 80 micromoles per litre. You need to know about the HLA-B 1052 allele, so anybody of Han Chinese or Thai origin, there's an increased risk of Stevens-Johnson syndrome, so you need to avoid this unless it's essential. And then obviously, if the patient has a rash while they've started the medication, this needs to be discontinued, and then if it's a mild rash, it can be reintroduced. This needs to be done by the specialist. You've got risk of suicidal thoughts, and then obviously you've got, with the injectable product phenytoin, risk of death and severe harm. And then obviously patients who have taken the medication are immobilized for a long time or have inadequate sun exposure at dietary intake of calcium, they need to be prescribed vitamin D. Key concept is that 100 milligram of phenytoin sodium is approximately equivalent to a therapeutic effect in 92 milligram of phenytoin base. Something that comes up in calculation questions all the time, really worth remembering this fact. Okay, now the next thing is an example of a calculation question. So patient JS is 45, weighs 80 kg, has been given 120 milligram twice per day of phenytoin sodium IV to treat tonic-clonic seizures. Due to a stock problem, this has been changed to Phenytoin, which is phenytoin base. So how do you work this out? Simple. So you've got your 120 milligrams of IV drug, 100 milligrams of the phenytoin, and then 92 milligrams in a phenytoin base form. So what you need to do here, you would do 120 times 92 divided by 100, which gives you 110.14 milligram per dose. Now they want the answer in milliliters, so what we then do here is we say that we have 110.14 milligram of phenytoin base is required in the Phenytoin solution. Find out how many mils is required, and then you just feed this in by simple concept of basically you can do ratios, or you can just find how much is in X. So if we use the find out how much is in X method, it's 18.4 mils. And this is an example of a question that would get presented to you. Okay. Potential OSCE situation. So you've got somebody being changed from phenytoin epinetine suspension to epinetine capsules, so basically phenytoin based to phenytoin sodium. So you've done the dose conversion, everything's correct. What things would you need to consider? So the first thing is you need to do the blood test for the phenytoin plasma concentration, and then obviously counselling on the signs of blood disorders as well, and even skin disorders. Next thing, patient checks is 90 is being prescribed phenytoin. They are to start on 100 milligram once daily for 2 weeks, increase their dose to 100 milligram twice a day for 1 week, and 300 milligram daily for 3 weeks. Work out the total number of 100 milligram capsules required for this prescription. So you can work it out, 91 capsules required. But what you notice is wrong here. Now, obviously, if you're doing advanced roles and you're working in practice and you've been presented with this situation, how are you going to deal with it? Because the thing is, you've got to think about things now. What's the wider context of the knowledge? What do you need to know about the patient? So the first thing is the patient is 90. Pharmacokinetically, you've got to think about things like metabolism, renal function. Is the patient able to take capsules as well? So swallowing. And then also you've got the issue 100 milligram twice a day for 1 week. So this was actually a real case where a consultant actually wrote the prescription incorrectly. The patient was 90, they had been tried on lamotrigine, they had been tried on levetiracetam, and basically they kept getting seizures, and they found that phenytoin was the best for them. But what should have happened was the patient should have been given 100 milligram twice a day for 3 weeks, and then start on the 300 milligram dose for 1 week and then be reviewed. So this was intercepted by a community pharmacist, and obviously they got the prescription adjusted. But one of the key things here is the take-home messages when you're doing your polypharmacy reviews, and even if somebody is taking phenytoin, are they having that yearly phenytoin blood test to check the phenytoin plasma concentration? Okay, so patient JC is prescribed phenytoin and has developed abdominal pain. They take amlodipine, lamotrigine, valsartan, and apixaban. What would be the best course of action for JC? Refer to A&E, sell buscopan for discomfort, refer to patient to the GP, refer to 111, take no action. Okay, abdominal pain, you straight away refer to A&E, classic red flag sign. So that's what you'd need to do here. Which drug is most likely to cause skin disorders, where patients need to be counselled on this and seek medical assistance urgently? Simvastatin, allopurinol, omeprazole, metformin. So obviously the answer here would be phenytoin. So in this type of question, what it's asking you here is obviously applying your knowledge of the patient care or advice and identifying which drug would be the main one. So it's just really more understanding your counselling. And then on the previous question, it was more like understanding your red flags. And this is how you could get presented with a phenytoin question in your GPHC exam. Thank you very much for listening to this presentation by CBH Education on anti-epileptics and in particular phenytoin. Please follow us on our YouTube channel, Facebook channel, and Instagram channel for more presentations on pharmacy revision, the legal concepts of prescribing, OTC medication, OTC conditions, red flags, and calculations.